足欢喜吼，会当访问到这个伫 UCLA 咧做心理医生的迄个 Walter Dunn 吼，Dan先生。Thank you for giving us this opportunity to for this visit. Okay.
Well, thank you. Glad to be here.
You know, psychiatric disorder is a very challenging topic for many people.
Mm-hmm.
So, can you tell us a little bit about how do you make the decision to become a psychiatrist?
Mm-hmm. Sure, yeah. So it certainly was not a linear path to medicine. So when after I graduated undergraduate at UC Berkeley, I actually went into a Ph.D. program to study infectious diseases. And during that time, this was wet lab work where you're sitting at a bench doing experiments. And I actually finished my Ph.D. and did a year of postdoc. But during the course of my Ph.D. work, my grandmother, my father's mother, was in a car accident and unfortunately passed away from that. But I got the opportunity to see the medical system at first hand. And so thinking about that event and then also what I wanted to do long term, I knew that even though the work I was doing for infectious diseases was important and would have long-term implications, I just knew that just my personality, I needed to have more immediate feedback in terms of application of what I was doing. So typically in research, your findings, your discoveries don't reach the patient until 20, maybe 30 years down the line. And for some folks, that's totally fine. They can do their experiments, they can write their papers, and that's fulfilling for them. But for myself, I knew that I wanted to have an immediate impact or a closer impact to people, because that's ultimately that's why we do research, to help people. And I was able to see that, even though my grandmother passed, I was able to see how medicine was able to help her during the last days of her life. And so then that's when I made the switch to go to medical school. And interestingly, when I first started medical school, the bottom three things that I didn't think I would consider were OBGYN and psychiatry. I didn't think I was going to be interested in that. Internal medicine, surgery was high on the list. And then, during third year of medical school, that's when you get an opportunity to see patients during your rotations. So first 2 years, pretty much classwork, some patient interaction. But third year is really where you do your rotations amongst the different specialties, and you get to see what the different specialties involve. And so that was really my first opportunity to see what we do in psychiatry. And I remember very clearly a manic patient that we were treating on the inpatient ward. So this woman came in floridly manic, singing, talking, made no sense. You could not understand anything that she was saying. And we started the medications on her. And a couple of days later, she was still talking really fast, acting very manic, but you could start to kind of understand what she was trying to convey to you or communicate to you. And over the course of 2 weeks, slowly, she started getting better day by day until one of the last days I was on the rotation. She was able to sit down like you and I and have a cogent, coherent conversation. And what really struck me was that she had insight into what had happened to her. That during the first couple weeks of hospitalization, she had no idea why she was there, why we were treating her. But the last day, she really had insight and regret in terms of, number one, coming off her meds, which is what brought her into the hospital in the first place. But really, she talked about how so much of her life had been, I think she used the word wasted during these manias where she'd be running around town, using drugs, acting unlike herself, right? Doing things that were not authentic to who she was. And to see that progression from completely disoriented and in a floridly manic state to someone who was able to sit down, have a coherent conversation, and appreciate her illness, that really struck me. And so that stayed with me for the rest of the time during third year of medical school. And so I really began to consider psychiatry more seriously, partly because my intention into going to medicine was not just to do clinical practice, but I wanted to stay in the research world as well because of my doctorate background. And so out of all the fields of medicine, psychiatry, we're the furthest behind everybody else, right? The cardiologists, the surgeons, the internists, they have a much better understanding of the illnesses that they're treating. They have a much better understanding of how their medications work, and psychiatry is still behind the pack, behind the rest of the pack. But that's because we're dealing with the most complex organ in our body, right? The brain, absolutely. The brain is by far the most complex organ that we're dealing with. And so, not surprisingly, there's still a lot to learn, a lot to know that we don't know about it. And so there's a lot of opportunities in psychiatry for research. And so that was another reason why I was drawn towards psychiatry, that we could, number one, make a big difference in people's lives, even though our understandings of the illnesses are still limited, but that there's still lots of exciting things to happen in our field, and perhaps maybe we can talk a little about those a little bit later. So then, fourth year of medical school is when you have to kind of decide what specialty you want to apply to. And ironically, not only did psychiatry move to the top of my list, OBGYN, as I mentioned before, which was at the very bottom, also moved. Actually, it was my number two choice. And again, that was because I got to see that OBGYN was a nice combination of medicine and surgery. And so I'm one of those psychiatrists that possibly if I did not become a psychiatrist, I would have become a surgeon. I like kind of to do things with my hands, to do kind of more mechanical hands-on things. And so OBGYN actually offered some of that. The maybe more cerebral internal medicine component, but then also the hands-on component of surgeries. But of course, the happiest time in medicine is when a child is born, right? And so that's what OBGYN gets to be involved in. So that's, of course, another huge reason why I was drawn toward that specialty. But psychiatry kind of made it to the very top, and that was kind of my roundabout way towards the field of psychiatry.
So you started working at UCLA in 2016? So
actually, I did my training at UCLA for my residency. So that's part of the Semel Institute for Neuroscience and Biobehavior, one of the world's premier psychiatry training programs. And so that was a 4-year training program. And then I started in 2010, so I completed that in 2014. And then from 2014 to 2016, I did a research fellowship at the West Los Angeles VA, which is literally right across the street from UCLA. And during training, I actually trained at both sites. But I did a 2-year research fellowship in psychotic disorders. And so when I finished that in 2016, that's when I officially joined the faculty as an assistant professor in 2016. But a dual appointment, actually. So both appointed at UCLA and then also the West LA VA.
Yeah. When I read your resume, you have a lot of titles. So I was trying to organize you what kind of work you've been doing. So you have been doing research at the UCLA, right?
Actually, a lot of my research takes place both at UCLA and the VA.
And the VA. Mm-hmm, mm-hmm. And you're also an educator too.
Yes.
You're also doing teaching.
Yes, teaching residents, medical students. That's also a big part of my responsibilities.
And are you also treating patients?
I'm also seeing patients as well. Right, yes.
Okay, and you also do some development of the training program for the psychiatry department, right? Yeah, the psychiatry,
the continuing medical education program.
And you also you also an advisors to the FDA.
Yeah, so one of my kind of specialties is clinical trials design, and so I've been involved in a organization called ISCTM, which stands for the International Society for Clinical Trials Methodology. So basically, that's how to design clinical trials more effectively, and because of that work there, and also some of my other work, I was approached by the FDA to serve on their psychopharmacologic advisory committee. So this is a group of advisors outside the FDA who are experts in their field. And when drugs go before the FDA to get reviewed and approved, they sometimes will call this committee to review the data to determine or help determine if it's safe or efficacious. And then this committee either votes to say, yes, you should approve, or no, you should not approve. Now, the FDA is not beholden to our decisions, but typically takes our recommendations in finally deciding whether a drug should be approved or not.
And the last but not least, you also organize conference and present in the conference too.
Yeah, this is a life of an academic, right? This is a life of academic. It's about teaching, it's about clinical care, it's about research. And all these things fit together, right? They're not. I never see them as kind of like individual siloed aspects of my responsibility.
Into the focus of your work. Tell me, what's your day like?
Well,
I don't know how you fit into all these roles.
Yeah.
With your days, your 24 hours and now 12 hours.
Yeah, no. So certainly my work day is not from 9 to 5, right? So the first thing I do in the day is actually get my daughter ready for school and take her to school. So that's actually one of the highlights of my day. There's a 20-minute drive to school. I drop her off. I give her a big hug and kiss, and I drop off my kids. Yeah.
That's so sweet.
And then, depending on the day, I'll either go to the VA first, or maybe I'll go to UCLA. But these days, mostly the VA. And then also, depending on the day of the week, there either may be resident clinics taking place, there may be my own clinics taking place, or I may have time reserved for administrative work or research. So really, no day is actually the same. So Mondays, for example, Monday mornings I have my own clinic, and that's where I see my own individual patients. And then in the afternoon, I have time, what we call protected for administrative or research. And so there I am.
Can I clarify something?
Sure.
Your patient is all in the hospital, or you do in the clinic too?
So yeah, good question. So actually I see mostly outpatients, so they're outside the hospital, but we also treat patients who have been hospitalized at the VA as well. So that's probably maybe 20% of our work. But my own individual clinics are all on the outpatient basis. And then the patients we treat, so my own patients are in our Ptsd clinic. So these are folks with diagnosed post-traumatic stress disorder. So that's a Monday. Tuesday is more reserved for education, administrative, and research. So I'm not directly necessarily seeing patients. And then Wednesdays is my heavy clinic teaching day. So both Wednesday morning and Wednesday afternoon, we have our what we call the mood disorders clinic at the VA. And so this clinic specializes in patients with treatment-resistant depression and bipolar disorder. But this is a resident clinic, so the resident physicians are the ones seeing the patients. And what generally happens is they see the patients, and then afterwards, before the patient goes, they come to my office and they staff with the attending physicians, going over, this is what we talked about, this is how the patient's doing, this is what I would like to do in terms of their treatment, either starting a medication or making an adjustment. And then we talk about the case for a bit, and then at the end of that conversation, we decide on what the treatment plan is, and then the resident physician will go back to the patient and say, okay, this is what we're going to do. And oftentimes I'll also go back just to meet the patient, say hi, review what the resident physician discussed with us or discussed with me, just to confirm that everything's accurate, and then essentially kind of give our blessing as far as the treatment plan that we discussed, and they go about their way, the patients. So that's a Wednesday Wednesday mornings and afternoons. And then Thursdays are my clinics, or my resident teaching clinic for our interventional psychiatry service. So in addition to being the director of the mood disorders clinic, I'm also the director of our interventional psychiatry service. So this is a field of psychiatry that's a little bit new. As the name implies, it's a more somatic-based treatment approach. So techniques such as transcranial magnetic stimulation, so this is a non-invasive brain stimulation technique that we offer. We offer new treatments such as ketamine and S-ketamine, so these are intranasal or IV delivered medications. Traditionally, interventional has also included older treatments such as electroconvulsive therapy or ECT. I'm in the process of getting that started for the VA, the West LA VA. But Thursday afternoons, that's our teaching clinic for that interventional psychiatry service. So there, the patients will be the residents will be evaluating patients who are interested or have been referred to us for those types of treatments. And again, we'll discuss the case, and then determine if this type of treatment is appropriate for the patient or not. And then we'll also teach the residents how to do some of these treatments. So we'll do a hands-on teaching with, like, this is how you use the magnet to do the stimulation, this is how you position it, these are the things that we tell the patient ahead of time what to expect for the stimulation. So that's again a big teaching and clinic day Thursdays. And Fridays is again more administrative and research focused. And sprinkled all amongst those are different lectures for medical students, for the residents. So, but that's one of the things I enjoy. I knew kind of starting just even before medical school that I'm the type of person that can't be doing the same thing day after day. I just get too bored, right? And so I need a little bit of variety in my day-to-day work, which, as you probably noticed, makes for a very busy day, because even after I come home, it's reading papers, it's reviewing articles, doing more research associated activities.
That sounds very impressive. Of course. Yeah. And I think a lot of your patients will benefit a lot from it. Next, I think you just kind of describe your work, but if you can kind of go into a little bit detail about your focus at UCLA.
Sure.
Okay.
Yeah.
And then we can talk about the VA medical center.
Yeah.
Okay.
So interestingly, my focus at UCLA is actually for veterans. So there's a program called Operation Mend, and this is a nonprofit program that was started in 2007 by Ron and Maddie Katz, and it was a nonprofit to provide veterans returning from post 9/11 conflicts with the world's best medical care, focused on plastic surgery and orthopedics. So a lot of these soldiers, Marines, airmen, sailors were coming back with very severe disfiguring burns, and the military medical system was doing the best they could. But we felt that the private medical sector could offer even more. And so a large portion of our patients in those early years, while there were still active conflicts going on, were getting plastics type treatment to address the disfiguring burns that they were receiving. And also a lot of orthopedics work for amputees. And so over time, this program has evolved to focus on PTSD and TBI. So as the major conflicts kind of died down, we were seeing less and less of the physical injuries, but the mental, psychological injuries of war we felt, or actually everybody saw, were not being addressed adequately. And I think that the DoD, the VA was doing the best they could, but there were still plenty of patients that were not recovering from their psychological injuries. And so Operation Mend shifted to a TBI, which is a traumatic brain injury, and PTSD focus. I'm the assistant medical director for the psychiatry portion of that program. And so what the program does is that it provides a 3-week on-site intensive treatment program. So patients generally come from all over the country to participate in this program, and they are working with therapists 9 to 5, Monday through Friday for 3 weeks straight. And in addition to the therapy component of it, we're also managing the medications, making adjustments, and then also adding on different types of therapies. So art therapies, equine therapy, so working with horses, in addition to our trauma-focused therapies, and then medication management. So oftentimes these patients are coming from VAs predominantly, and they've tried a lot of different medications, which maybe haven't worked as well as they could have. But oftentimes there are things that they haven't tried or that need to be tried again. And so that's my job as the psychiatrist, is to kind of go over the history, figure out which medication trials have been adequate in terms of length and dose, and which ones could they possibly try again to help some of their symptoms. So oftentimes nightmares are a big component of PTSD, and that's one of the I would say top 3 symptoms that patients suffer from. And we do have some treatments for
top 3 symptoms
for PTSD.
Okay.
Yeah.
Nightmare and what?
Oh, I would say nightmares, disrupted sleep and hypervigilance. Hypervigilance meaning that they're constantly on guard, worrying about threats in their environment. Even, they could be sitting here having a conversation, and then their mind will still be thinking about, is this a dangerous situation, right?
I mean, they cannot control it.
It's something, yeah. It's something that, that part of the brain is overactive, right? They've been, they've been trained, they've been in a combat zone for so long that part of that brain is difficult to shut off.
And you were talking disrupted sleep?
Disrupted sleep. Mm-hmm.
Because a nightmare, or is because you just could not sleep?
Yeah, nightmares, yeah. Oftentimes it's nightmares, but you've got plenty of patients where, doc, I sleep like 2 or 3 hours a night. I'm waking up every hour. I don't think I'm having nightmares, and they may not be, but their body is so revved up and on guard for potential threats that it's not allowing them to go into deep sleep, right?
In terms of PTSD, I thought most of people may be thinking they are all the same in a way. Is that a lot of individual difference?
Absolutely. So, the way we understand or define PTSD is that this results from a trauma, a life-threatening trauma. This is something that you could have experienced yourself. It's actually something you could have witnessed or even heard about, depending on how close the person was to you who suffered that trauma. And then the way we define PTSD, we have something called the DSM, right? This is the diagnostic statistical manual we use in psychiatry. And in the most recent version, which is the DSM-5, there's 4 major symptom categories. And they have different types of symptoms you can have. Some of them you need to have 2 symptoms, some of them you need to have 1. But interestingly, you ask, how many different types of PTSD are there? If you take every different combination that's possible, there's about 600,000 ways you can meet criteria for PTSD depending on which type of symptoms that you're experiencing. Now, that doesn't mean there's 600,000 different types of PTSD, but we certainly believe that there are probably different mechanisms arriving at similar symptom clusters, so that depending on your genetics, depending on your type of trauma, depending on your biology, your genetics, that there's different pathways, because we know there's some patients who respond very well to our standard treatments, but some patients who don't respond. And so there has to be probably something underlying that's making that difference. But that's one of the frustrating things about psychiatry is that we call depression kind of one thing, right? We call schizophrenia one thing, we call bipolar one thing. When we know that there's multiple different types of depression, there's multiple different types of schizophrenia, there's multiple different types of bipolar disorder, but we don't understand the pathophysiology or the mechanisms behind it to elucidate them so that we can determine, oh, you have type 1, so you need this type of treatment. You have type 3, so you need this type of treatment. This is where the field is moving towards. But just like those other illnesses, PTSD, now, PTSD is interesting in the sense that they do share the unique feature that there has to be a traumatic event triggering it. So in the sense that's the same, but I think how the illness develops, there's different pathways from that inciting event.
So are you saying that the outpatient that you are treating at the UCLA is from the veterans?
So our program is...
What I'm trying to say, what I'm trying to ask is you're talking about PTSD from the Operation Mend Program.
Mm-hmm.
I'm just kind of curious that is your main focus, or you also treating the other
types
psychiatric disorders?
Oh, I see.
Or from the, say, private insurance or whatever?
Right. So for Operation Mend, that program is specifically for veterans from post-9/11 operations. So they're all military veterans. They all have some... Now, they may not be coming for combat trauma, right? So we have plenty of veterans who served post-9/11, did not see combat, but experienced trauma in other ways. So military sexual trauma, unfortunately, is a big thing. And so we have veterans that we treat that, again, were never in a war zone, but were the victims of military sexual trauma. We have veterans who their trauma really is from childhood trauma, right? And that's the trauma that we're treating. But they all share the common feature that they're veterans who served in post 9/11. Their trauma doesn't have to come from military combat. And so that program, again, this is all provided free of charge. But I also do other work at UCLA. For example, I'm one of the attending physicians in our psychosis clinic. And so that, again, completely separate from Operation Mend. There, it's a teaching clinic for patients with schizophrenia. But those are two of my main focuses at UCLA.
Schizophrenia? How about bipolar? Because I thought one of your either the research or thesis is also about bipolar and depression.
Yeah.
Are they also kind of included, or are they similar, or I'm not really sure about
that? Yeah, so my work with our treatment-resistant depression folks and bipolar folks is actually at the VA across the street. So at the VA, I'm the director of the Mood Disorders Clinic, and there, these are veterans who have depression that has not responded to our standard treatment, so they need something a little more advanced, or these are patients with bipolar disorder. So for those mood disorders, I'm treating those at the VA. Whereas for the psychotic disorders and for PTSD, I'm actually treating them at UCLA. But I also treat patients with PTSD at the VA also.
Can I ask you a question? I just thought about it. When a person experiences some kind of traumatic injury in their life, the symptom could be different, right?
Yeah.
It could be depression, but it could be what you define as PTSD, or it could be, I don't know, schizophrenia? Is it possible? Well, I'm not sure how you would call it. I know that's a different kind of definition in terms of books, but I'm just trying to say is like, when people went through the trauma, their symptom could be different.
Yes, absolutely. Yeah. Certainly the trauma can result in a severe depression. It can cause PTSD. Anxiety is a big one, right? So you may not meet criteria for PTSD, but you may be anxious and hypervigilant, right? If you think about our response to a trauma. So trauma is an injury, right? Either physical or potentially psychological. Your body, your brain is designed to protect you against injury. That's how we survive, right? We step into the street without looking both ways, and we almost get hit by a car. The next time you step in the street, you're going to look both ways, right? So the result of that trauma is your brain telling you, don't make that same mistake again. And one of the ways to do that is to elevate your anxiety so that you're constantly kind of looking out for potential threats. Now, so that's a normal response. But for whatever reason, in pathological conditions, that anxiety or that protective mechanism is ramped up perhaps a little too high. And then it starts to cause problems in terms of functioning on a day-to-day basis. And so that's when people come see us. Right, because the way I like to explain it is that PTSD, you don't necessarily develop PTSD. It's actually the lack of resolution of those protective mechanisms. So if you take 100 people and you expose them all to the same trauma, within the first week or first 2 weeks, they'll all have PTSD-like symptoms. They're probably not sleeping well, having nightmares, hypervigilant, right? But then over time, those symptoms start to resolve for most of the folks, right? They start to sleep better, nightmares aren't as prevalent. But for whatever reason, after a month, after 2 months, after 6 months, there's a small percentage, it varies, it can be from like 5 to 10% of those folks still are not sleeping well, still having nightmares, still hypervigilant. And so it's really, so the one way to think of it is that PTSD develops because those mechanisms, protective mechanisms, don't resolve after time.
So far, we still don't know why it couldn't be resolved.
We don't know. We know that for whatever reason, folks with childhood trauma, when they were exposed to like a later trauma in their adult lives, have a higher propensity or at higher risk for developing PTSD. But beyond that, there's not a lot of good understanding as to why their kind of resolution mechanisms are somehow impaired or a little bit different from somebody else who doesn't eventually develop PTSD.
Could be in the genes.
It could be in the genes. It could be
in life.
Absolutely, their environment.
So it could be different. So we're talking about the disease, kind of a little bit depression right now.
Mm-hmm.
So let me ask you something. So far, the treatment that you guys are doing at UCLA or VA hospital,
Mm-hmm.
You would say there's an individual difference, but what's it effective right now, in a way? I know it's a very general question, because you were talking about TMS and
Mm-hmm.
ECT and Ketamine.
Yep.
I'm not sure why you pointed out these three as a focus.
Yeah.
Can you explain that a little bit more?
Sure, absolutely. So it's kind of to your general question of which one is most effective, right? In medicine, the safe answer is it depends, right? And it's also a balance between risk and benefit. So we have a pretty standard algorithm we go through when we're treating patients for depression, right? So our serotonin reuptake inhibitors, or SSRIs, are generally our first-line medication-based treatments. So medications like Prozac, Lexapro, Zoloft, these are all very common SSRIs that are prescribed. We know that
those medications take a while.
yes, yeah, they take like 6 to 8 weeks to reach maximum effect.
That's very difficult for family to deal with it sometimes, because at that time you're still witnessing the hallucination, and all the kind of weird behavior or maybe insomnia and stuff like that. The 6-8 weeks is very difficult.
It's very challenging, not only for the family, for the patients, right? For the patients as well. So when I tell people 6 to 8 weeks for full resolution, it doesn't mean that you can't start feeling better earlier on. So generally, probably around week 2 or week 3, patients who are going to respond to those medications will begin to tell me, doc, I'm feeling a little bit better. I'm not all the way better, but I'm feeling definitely a little bit different than I did 2 or 3 weeks ago. And then over the next couple of weeks, then they start to achieve even more resolution. So the SSRIs are our safest medication. So interestingly, psychiatrists aren't the biggest prescribers of those meds. It's actually primary care docs. So a lot of first-line depression is addressed by your family doctors, your internists. But unfortunately, only about a third of our patients will reach remission, meaning that their symptoms completely resolve with those first-line medications. And so there have been plenty of studies done showing that, yes, if you go through 4 or 5 different medication trials, there are still patients who are very symptomatic. And so those patients they have what we call in the field treatment-resistant depression, right? And so that's my specialty. So the interventional clinic that I run, these treatments that I talked about, the TMS, the transcranial magnetic stimulation, the ketamine, the ECT, those are reserved for patients who have not responded to our first, second, third line treatments. And that's because they're very resource intensive. They potentially can have a high side effect burden, and they're just not that easy to use. You have to come in to get these things. It's not as easy as taking a pill every morning.
They usually need to be hospitalized, or you just need to as a day treatment?
Yeah, they can all be done as a day treatment. So for TMS, they need to come in because the machine is in our clinic. So they come in, sit in the chair, get the stimulation, depending on the protocol, between 5 or 30 minutes, and then they're done and they can go home. But they need to come every single day for 6 weeks. So you can imagine for someone who's working or going to school, and especially commuting here in Los Angeles, that can be a very challenging or daunting endeavor, right? So that's why it's not something that's necessarily offered as a first-line treatment. The other thing is that only one person can sit in the chair at any given time. These machines are $50,000 to $80,000, and it needs to be run by someone with a medical background, right? So there's just not the capacity for everybody to get TMS as their first-line treatment. So we typically reserve it for folks who have not tolerated or who have not benefited to our SSRIs or SNRIs. And then you mentioned ketamine. So ketamine is interesting. So this is something that is actually quite widely available around Los Angeles. But this is an old anesthetic that was approved back in the 1970s. And it wasn't until the early 2000s that they serendipitously found out that this could work as an antidepressant. And not only could it work as an antidepressant, it worked as a rapid-acting antidepressant. You talked earlier about how medications take 6 to 8 weeks to reach maximum effect. For some patients, after an infusion of ketamine, they can be feeling better after 4 hours. So it's pretty remarkable.
Really?
So yeah, that's not something that we see in psychiatry very often. So it's something that really kind of caught a lot of psychiatrists' attention when this has started to come onto the scene. But again, there are limitations, right? You have to come in, you have to get an IV placed, you have to be monitored for 3 hours afterwards to make sure that you're no longer hallucinating before you you can go home. So you can't have that many patients coming in for it. Also, it's contraindicated, meaning that we can't give it to, or we shouldn't give it to people with a history of psychosis. So if you've got schizophrenia and depression, most likely you would not be a safe candidate for an IV ketamine infusion. So it's limited in that sense where, again, it's about resources, right? How many patients can actually receive this? And then ECT, of course, electroconvulsive therapy, that you require actually anesthesiology and a psychiatrist. And so you need to, when you come in and you get the treatment.
Hold on a second. You need an anesthesiologist for ECT?
For ECT, yeah. So the way we practice it in the United States, modern ECT, back in the day, it wasn't done with any anesthesiology, right? It wasn't done with general anesthetics. People were awake. But it can be a very distressing response or experience. And so modern ECT is done with anesthesia. You're only under for probably like a minute or two. They don't even actually start an airway, but you're getting a general anesthetic, you're given a paralytic, so that when you have the seizure, you're not breaking bones because you're actually not moving. So as you can imagine, that's a very resource-intensive treatment that is generally reserved for our most severe refractory cases. And that's something that general psychiatrists aren't necessarily trained in. So just as in any other field of medicine, you have people who kind of specialize in the first or second line treatments, or maybe everybody can do that. But the more kind of involved, resource-intensive treatments, you have specialists. And so that's my focus at the VA in that mood disorders clinic and the interventional psychiatry service. We focus on patients who have not done well or have not responded to our initial treatments, and they need something more specialized.